Hello, everyone. It gives me great pleasure to welcome you and to this talk on training and implementation for minimally invasive pancreatic surgery. I am so honored to join the likes of Dr. Shah, Dilhoff, Vreeland, Erin Baker, and of course the genesis behind all of the data that we have on minimally invasive pancreatic surgery, Horacio Asbin. My job today is to talk to you about implementation. And so I've put together a talk that hopefully will go through some of my ideas. So first of all, my disclosures, I have a consultancy agreement with Certex and with AngioDynamics. So what are the challenges with minimally invasive pancreatic surgery? Well, the first thing is it's technically hard, right? This is the golden grail of surgery for many of us during our residency training program. The number of Whipples that you do is sort of the distinguishing factor with your program. Minimally invasive pancreatic surgery requires a different skill set than open. It requires knowledge of the open operation, but also the knowledge of minimally invasive skill set, for example, the instrumentation, the robotic platform, etc., if you're using robotics. We need to have the ability for rescue. So in these cases, like with open operations, we do have the need for sometimes dealing with urgent issues as far as blood loss, etc. But the differences here are that the ability to control bleeding minimally invasively can be different, and the skill set to control this can be different than in the open circumstance. And I must say a shout out to our anesthesiologists that really help us in these moments. And more than ever, you need a team. So you need scrub techs, circulating nurses, etc., that are used to dealing with the issues around minimally invasive surgery. And what this means is the following, especially with pancreatic duodenectomy, there's a specific skill set, knowing the operation, knowing the anatomy. There is an MIS skill set, so for example, knowing the platform of robotics is critical. If you're using robotic surgery, which is kind of our go-to, you need the ability to rescue, as mentioned, the anesthesiologist and the blood bank, etc. And then you need the team itself in the operating room that actually knows how to provide you with the pieces of equipment that you might require. And all of this is centered around the patient. And what that means is there's this very small area of overlap of all of these that we as surgeons need to maximize and use for our patients' safety and benefit. So what do we know? Well, we know that distal pancreatectomy has a safer learning curve than a pancreatic duodenectomy. And what that means is that the mortality with distal pancreatectomy in general is lower than with pancreatic duodenectomy. And kind of for me, the way I think about this is the pancreatic duodenectomy is 3 operations in one, right? A pancreas, biliary, and a bowel operation. Whereas the distal panc has no anastomoses. So that's not unexpected. And I just wanted to go through some of the data. One is the LELAPS 1 program in Holland, which was a nationwide program for laparoscopic distal pancreatectomy. They had many surgeons in many centers, and this was one of the criticisms of this program. But they went through a standardized video-based training program and in-person training program, and then were proctored before they were allowed to enroll in the study. So the Dutch do a fabulous job with these randomized trials. And what they found was that with a dedicated training program, you increased the number of minimally invasive pancreatectomies, distal pancreatectomies, and there were less conversions and decreased length of stay, all of which were positive results that would suggest that dedicated training in this arena can make a difference. And I don't want to get into this too much, but there are multiple studies here showing that minimally invasive pancreatic resections, distal pancreatectomy for this cohort resulted in improved length of stay, and that the learning curve may be somewhere in the 10 range. So a fairly quick learning curve. So this data would suggest that distal pancreatectomy is teachable. has a reasonable learning curve and can be done safely. And again, the mortality, which really is ultimately one of the key issues here as far as safety goes, is good for this operation. How about pancreatic duodenectomy? So I illustrated this for our medical students for anatomy, but you can see you're by the portal vein, you're by the hepatic artery. This is sort of the center of the soul, right? So I always say that the closer you are to the portal vein, the vena cava, the aorta, and the hepatic veins dictates the complexity or the risk of the operation. So when we talk about the pancreatic duodenectomy, we have some data on open pancreatic duodenectomy, specifically the papers from MD Anderson when Jenny Seng was there in 2007, outlining that there was somewhere around 60 cases to get to expertise. In Dr. Schmidt's paper from Indiana, he got the data somewhere around 50 cases, which resulted in a lower perioperative morbidity. With regard to robotic distal pancreatic duodenectomy, the Melissa Hogg group and Herb Zay's group and Amir Sarakat's group showed that 80 cases robotically was sort of the tipping point to decreased operating time. And there were some other oncologic parameters that improved too at that point. And so we need to ask ourselves, should our curves look like this, with 60 being the first inflection and then another 80 being the next inflection for robotic cases? Or is there a way that we can make the learning curves concurrent rather than sequential, so that we can get to a mastery or at around 80 cases altogether? And really, we need to look at safety also. I have some thoughts with regard to how to make these curves synchronous rather than metachronous, so to speak, and we'll talk about that later on in my presentation. So we also need to look at safety, right? And this was, I think, a very alarming study because it really did speak to some of us that know that there are some horrible outcomes out there for pancreatic duodenectomy done minimally invasively, especially in very low volume hospitals. So this was the Leopard 2 trial where the institution needed to do greater than 20 pancreatic duodenectomies a year. Most of the cases that were accrued were at 4 sites. This study was prematurely closed, and the reason was that the mortality was greater in the laparoscopic pancreatic duodenectomy group compared to the open group, so 10% compared to 2%. Sorry, this belonged here, and the complication rate was 50% compared to 20%, and these were major complications. And this caused this trial to close and caused a lot of us to stop and question whether safety was, a critical issue with minimally invasive pancreatic duodenectomy. The volume of the institution also matters, which is really an issue too. So Kutlu's study, I think, was a nice one. I know Onur well, and I think this was a very nicely done study where the institutions were divided into quartiles, and if you had greater than 25 pancreatic duodenectomies at an institution, greater than 10 minimally invasive, there was a clear improvement in outcomes. So now some of my thoughts. How can we make this safer? Well, you need to know your instrument. I believe that translation from other procedures is critical. And I believe this ever since I was a trainee. And I wish that some of our trainees would take this a little bit more seriously, because I do think that expertise in other areas does translate into expertise in other areas. So therefore, vascular expertise can be used in other sites. For us, I think the foregut cases have been some of our critical areas of growth. Minimally invasively, for example, esophagectomies are stapled mostly, and you can really work on your instrument skills rather than your suturing skills to begin with. I believe that you need to get over your LD50, which is the lethal dose 50, during fellowship. I think that we did this with lap chole, and we got to that 40 number during residency, and we need to do this with pancreatic operations and get through the learning curve for distal panc as well as for pancreatic duodenectomy during fellowship. I believe that that's 60 for open pancreatic duodenectomy, and I think we owe it to our fellows to give them that number of cases. This is not always easy at a lot of institutions, however. And just to kind of tell you where we stand, this is overall, these are our fellows case logs from the HPB fellowships in North America. And you can see that overall, not a ton of cases are being done laparoscopically or robotically. When you look at distal panc specifically, you can see that most institutions are doing some, but there are some that are doing none, and there are some that are doing mostly MIS. We've now included a requirement for MIS distal pancreatectomy to try to move the needle on this topic. So we have robust training requirements for the hepatobiliary programs in North America. There are 25 pancreas cases required, of which 5 must be MIS distal pancreatectomies, and there are 20 pancreatic duodenectomies required. Most programs meet and surpass these requirements easily. Once you're done with fellowship, I think you need a mentorship program. You need to have somebody available to you that knows the surgery, that knows the instrument, and you need a team. So what that means for us is that we rely on each other. I'm sort of the old guy, so I tend to help with the expertise portion of this with my junior colleagues but we all work together. Credentialing, of course, is another issue, and this is a local process. We can't really get into this too much, except to say that I do think that there is an opportunity for improvement here, and I think there needs to be ongoing quality metrics in order to ensure that people stay credentialed in these areas, and I think that this is something that we need to think about. The institution volume is also important, and allied services, for example, trauma and transplant, can make the infrastructure easier to build within the institution. I think you need to watch your own outcomes. And one alarming trend that we saw, which was not statistically significant, but was something we are keeping an eye on, is that converted Whipples from MIS had a higher mortality compared to those completed or open pancreatic duodenectomy. So this is something we are keeping a close monitor on. Just to show you some of our data. So when we looked at our distal pancreatectomy experience robotically, we used something called the CUSUM analysis. So we have an amazing medical student who's quite good statistically. And what he looked at was the operating times as a variation from mean. And you can see what you see with this is that you get a peak and then a plateau and then a drop. And the peak shows to comfort. So this is what most people call sort of the learning curve. And that we found at 11, whereas to mastery, we actually got to 48, which is a little bit higher than other studies. Now, interestingly, for the helimyotomy, this CUSUM curve really was very, very flat in that we very quickly got to comfort with this operation, and it was really a pretty quick curve to expertise. For robotic pancreatic duodenectomy, it was 17 to comfort, and then 51 to expertise or mastery. And so a little bit quicker than some of the other curves, and I'll sort of think that this is because we've learned from others, and I think that this is one of the key concepts here. So in conclusion, I believe that MIS cases help steepen the learning curve when you're doing other MIS cases. So for us, the foregut arena or colorectal arena are 2 other areas that we perform quite a bit of MIS and robotic surgery on, and we see that this helps us when we're doing the more complex operations like Whipples. I think that that's not a huge surprise, but it seems to be surprising to many people that just do hepatobiliary. So I also think that a formal fellowship training program is critical. You've seen that the Dutch have shown really a benefit to a formalized training program. And I think that you need mentors. These are people that will help you. And above all, be safe. It's important to be safe and look at your outcomes constantly and make sure that you are being safe and that your outcomes are where they are. So overall, I want to thank you very much for joining this session, and we're thrilled to be asked to be part of this group. And we look forward to working with you in any way that we can to make pancreatic surgery minimally invasively safer. Thank you.